Good evening, friends. Today, once again, we'll go to the basics of ECG. This is fifth class of the basics. Okay, hope you people are following it. So, today we will be looking into another topic that
Yeah.
Sir, voice not audible, sir. கேட்கல sir.
now am I audible?
Yes, now audible, sir.
Oh, fine. Then I'll start from the beginning so that the session is there. So I'll start from the beginning because it was not audible. Sorry about it because there is a small internet positivity capacity in my place. So I'll just start begin with. So a couple of weeks back, we started about the ST elevation. Last week, we were talking about ST segment elevation equivalence. So both are important. Now we will be talking about the next thing where there is a ST segment. This is the ST segment which normally we see. So the ST segment, this is the corresponding phase of the action potential in the heart, cardiomyocyte. And the same thing will be seen in the ECG as the ST segment. See here in the action potential, what happens in the cardiac myocyte? There is a silent phase. There is some, from this 0 to 1, there is a elevation. Then you have a silent phase, then it comes in. This phase is meant for depolarization. That is the QRS complex, right? So this phase is relaxation, repolarization, that is the T wave. So now you understand, between these two phases, you have got a silent isoelectric ischemia, isoelectric changes, which is called ST segment. So when there is an ischemia which is happening within this, in some coronary artery territory, this ischemia disturbs this silent phase. So ST segment is disturbed, and ST segment, either if there is going to be epicardial ST territory is involved, then you have ST elevation. When there is subendocardial ischemia, then there is going to be ST depression. Now you understand why ST segment elevation and ST depression happens. During the silent phase, when every heart, all the areas are silent and no activity happens, there is isoelectric ST segment. When there is going to be ischemia, then you will find ST segment elevation if there is going to be epicardial ischemia. If there is going to be subendocardial ischemia, there is ST segment depression. So where do you measure all these points? See here. I'm sorry, there is something abnormal in the way it is behaving. So when you have these measuring points, you find the J point is the one place where you have to measure the ST segment elevation or depression. See here, as I already told you, from the PR segment most of the time, or the TP segment, you will make an imaginary line. If it is above that, we call it as ST elevation. If it is below that, we call it as ST depression. The J point should be above to call ST elevation, should be below, you call it as ST depression. So primary STT changes, that means when there is going to be abnormal repolarization, that is nothing to do with the QRS complex. QRS complex is depolarization. When there is abnormal repolarization, there is ischemia happening or some electrical disturbance happening, there will be some changes in the ST segment. So you just carry the message, primary STT changes are abnormal repolarization as seen in ischemia or electrical disturbance. Whereas secondary STT changes are related to abnormal depolarization. This means there is an abnormality in the QRS complex. This abnormal QRS complex causes abnormal repolarization. There is an abnormal QRS complex, and this abnormal QRS complex will cause abnormal repolarization, right? So when there is widening of QRS complex, the STT T wave will be abnormal. That is the point. So when widening of QRS complex happens, or at height of QRS complex increase, secondary to that, there is a STT changes. We call it as secondary STT changes. When nothing happens to the QRS complex, only ST segment elevation and depression is happening, you call it as primary STT changes. See here, not all STT changes are abnormal. If you happen to see, there is an upsloping ST segment. So upsloping means the J point appears depressed, but within one small square or 1.5 small square, it will reach the baseline and will form a STT segment. This is called upsloping ST segment. Within 1 to 2 small squares, this rapidly, the slope of the ST segment increases to become normal and form the T wave. If this is happening, means most of the time it is normal. So you have to understand, most of the time it is normal. When there is going to be upsloping ST segment, it happens during treadmill because of the atrial depolarization. There is supposed to be some ST depression which is happening, and this atrial repolarization is happening, and this can cause ST depression, and there is upsloping ST depression happening, which is not ischemia. The message is very clear. See the picture, it is all pattern recognition. See the picture, there is an upsloping ST depression. Somewhere in the middle, you can have some non-specific STT changes. See, there is no apparent ST depression. J point seems to be in the baseline. There is a slight depression, and the terminal T wave is positive. When there is ischemia, the T wave will be negative. Carry home message. Ischemia, 99% T wave, terminal T wave will be negative. When there is T wave is positive, followed by another hum, which call it as U wave, this will be like a hypokalemia. Whereas in digoxin poisoning, you can see here there is a inverted tick mark appearance, digoxin overdose or digoxin digitalization. You will find this inverted tick. It is only pattern recognition. Just see this pattern, and if you see it in the patient who takes on digoxin for a long time, then you see the digoxin pattern, that is inverted tick mark appearance. But the most important point is, whenever there is a tachycardia and you find a ST depression and rapidly becoming normal within 1 or 2, 1.5 small squares, you call it as upsloping ST segment depression, right? How will be the ischemia? See here the ischemic changes. There will be a typical horizontal ST depression. The message is very clear. Typical horizontal ST depression. The J point is depressed. See here, the J point is decreased, suppressed, and it is ST depression happens, and there is a horizontality. Or the other way of ischemia is there is a downsloping ST depression, which is happening. So these two are the classic way of explaining the ischemic changes. The real life examples will be like this, where you have a horizontal ST depression, downsloping positive ST depression, inverted T wave will be there, horizontal ST depression with short serum. So if you happen to see all these type of STT changes, most of the time you are dealing with ischemia. See here the classic example of ST depression and T inverse going up, and this is a downsloping ST depression. What happens after the ST depression? The classic ischemia, there will be after ST depression, there will be a sudden abrupt transition from ST to T. There will not be a smooth transition. So every point is very important. From ST to T, there should be a smooth transition. When it is not happening, when it is happening abruptly, see here there is an abrupt ST segment from there to T wave. There is no smooth transition. Here again, there is a deep T wave. From there, it abruptly rises. So just see this pattern. And if you keeping on seeing this pattern and seeing the ECG, and if this happens, then it is ischemia. Multiple occasions you will find ST depression. Not every ST depression is ischemic. You have to understand the differentiate between ischemia and non-ischemia. That is very vital when the patient has an acute chest pain in a casualty. Right? So this is all primary STT, that is all ischemic. But I told you there is secondary STT changes. How this happens? It is because the QRS complex is either wide or very tall. Two changes, very wide or very tall. Where the wide happens? When there is bundle branch block. When there is a left bundle branch block happens, or there is a right bundle branch block, or pre-excitation, then you have a wide QRS complex. Because of the wide QRS complex, the repolarization is also repolarization is abnormal because different areas of the ventricles are activated at different time. So repolarization also happens in a different time. So you have secondary STT changes where opposite to the QRS complex, there will be a TST and T wave. Opposite to the QRS. When there is a large area of myocardium to be traveled, like in a left ventricular hypertrophy or right ventricular hypertrophy, there will be a secondary STT changes. See here, when the QRS is wide, depolarization abnormality happens. Because the ventricles are depolarized in a varying time, repolarization is also happening in a varying time. Right? That is the reason why there is secondary STT changes. When the QRS myocardium is thicker, like in left ventricular hypertrophy, it takes longer duration. So varying ventricular activation. So repolarization, depolarization is also varying. So you have secondary STT changes. So you should never forget these 2 points. One is wide in QRS complex, always STT will be opposite to the QRS complex, right? When the STT changes, QRS is very tall, most of the time it will be opposite to the QRS complex, right? You understand 2 occasions where STT changes, secondary repolarization abnormality happens. That is normal, that is not abnormal, that is not ischemic. So carry your message is very clear, that is not ischemic, right? Moving on from the STT, now I'll go to the T wave, which is very important. This is part of ST segment. The transition from ST to T segment should be smooth, whereas in ischemia, it is always abrupt. So you saw the picture, it is always abrupt. From ST segment to T wave, there is no smooth, it is abrupt. So another, see this slide is full of carry your message. Amplitude of T wave is rarely more than 6 millimeter in limb leads, right? So it's always smaller. It depends on the QRS complex. When the QRS complex is small, it is T wave is also small, because whatever happens, when the depolarization, relaxation is much smaller. In the chest leads, the amplitude in V2 and V3 is the T wave is the highest, right? The males may display up to 10 millimeter, but females have a lesser amplitude. T wave amplitude is average 3 millimeter in V2, V3 in females, whereas it 6 or 7 millimeters in males. Usually, it depends on the QRS. If the QRS complex is high, the T wave will also be taller, right? Usually, the last line is very important. The normal T wave is slightly asymmetric. Ischemic T, whether it's upright or inverted, will always be symmetric. That is another carry over. If it is asymmetric, you have to suspect whether it is ischemia or not. Asymmetric, the slope of the descending limb is slightly deeper and steeper than the ascending. So ascending limb slowly grows up and the descending limb is rapidly coming down. This is all the T wave will be. We'll see. Then the T wave, how T wave should be? It should be concordant with the QRS complex. The QRS complex is not wide, QRS complex not taller, then it should be concordant. It means it predominantly on the most of the QRS complex side. So here see the QRS complex predominantly positive, the T wave is also positive. This is called concordant QRST. So it means whenever the QRS is positive, you should have the T wave should also be positive. Whereas predominantly negative wave, it is opposite to that, means wide QRS complex, opposite to that, like a LBBB or RBBB, you have a discordant QRS and T. This is called secondary STT changes. Now you understand why this happened, what is concordant, what is discordant. Concordant is same side of the QRS complex, discordant is opposite. Normally opposite happens when there is QRS is complex wide or it is very tall, right? So normal T wave is like this. See here, the ascending limb is smooth transition. Ascending limb is slowly growing up and it is longer. Descending limb is steeply coming down, it is shorter. This is all the normal T wave. Whereas a narrow base, steep and tented T wave, we call it as hyperkalemia. Whereas a hyperacute T, last class we saw wide base, blunted apex, and a tall T wave. You call it as hyperacute T wave. Now you differentiate between hyperkalemia and hyperacute T wave, normal T wave. You see the difference between these two. The ST segment is smooth, whereas here ST segment J point is elevated. ST segment is smooth, appears smooth, but narrow base, tall T wave, peak T wave, tented T wave. This is hyperkalemia, this is hyperacute T wave, right? So the most important here for ischemia is inverted negative T wave. T wave inversion means that the T wave is negative. By definition, the T wave is negative. The terminal portion of the T wave is below the baseline. T wave inversions are actually graded mild, 1 to 5 millimeter. Just it is possible ischemia. Deep T wave inversion or sometimes gigantic T wave inversion. Usually the gigantic T wave inversion occurs in a CVA. Deep T wave inversion will be there. You see it in hypertrophic cardiomyopathy like that. So myocardial ischemia, usually there will be flattening and mild T wave inversion. See here, there will be another terminology called biphasic. See this biphasic T wave. Initially it is positive, then it is negative. Here it is initially negative, then it is positive. Here it looks like hypokalemia. Here looks more of ischemia. The terminal negativity always suggests ischemia. Terminal positivity of the T wave, we should look into other causes. Here possibly there should be a hypokalemia, right? So the negative T wave, see here the ischemic T, symmetrical, that is most important. Symmetrical. You just keep remembering this word. Symmetrical, ascending limb and descending limb are the equal, and acute ongoing ischemia, there is also symmetrical T wave, and the cerebrovascular insult, there is a deep T wave, HCM deep T wave, and when you have deep and gross T wave inversion, post CVA can happen. So we'll see the T wave abnormalities one by one. Peak T wave, hyperacute T waves, inverted T waves, biphasic, camel hump, flattened T wave are the various T waves we can see. Peak T waves. See here it is peak, tented, ST segment is present, narrow base, tall T, and tented T, apex is very peak. Then it is simple, hyperkalemia. You look at this ECG, you will never forget hyperkalemia. Hyperacute T waves, I told you broad asymmetrical peaked hyperacute T waves are seen in the early stages of ST elevation. It is transient within 30, 40, 1 hour. After that, you find there is a ST segment elevation. So here you find this hyperacute T wave. See here, broad base, smooth transition, J point is elevating, and a blunt apex. It's not a tented peak like a hyperkalemia. Tall T wave. So this is a typical of hyperacute T wave, right? So the next moving into the ischemic T, inverted T waves. So usually, because while in embryology, in the embryological stage, usually the right ventricle is equally dominant. So after birth also, for the next 10, 12 years, children will have equal dominance sort of ECG. That is so T wave, inverted T waves in anterior leads, V2, V3, V4, V5, everything might be inverted. That will be a normal finding in children. Do not panic about inverted T in children. That is normal. Sometimes it persists in females for a longer age, 30, 40 years also. You call it as juvenile pattern, persistent juvenile T wave. Sometimes the T wave inverted could be the most important myocardial ischemia and infarction. Predominantly, I told you, symmetrical T wave inversion. The bundle branch block is the secondary STT changes. White QRS complex. Secondarily, there will be STT on the opposite side. Ventricular hypertrophy, left ventricular, right ventricular hypertrophy. Here, you have the height of the QRS complex increases, means there will be secondary STT changes happening. In right ventricular, strain in pulmonary embolism or a HCM can have STT changes. I told you about the raised intracranial pressure. CVA can cause deepest T wave will be seen, bizarre T wave will be seen in that area. Pediatric patients, see here, V2, V3, you will find normally a T wave inversion, which you should not panic and brand as ischemia. It is a normal variant in the pediatric age group because the RV forces is still there in the ECG. Persistent juvenile pattern, see here in the females, most of the time in the females, middle-aged female, costochondritis, the patient comes with the chest pain, you find this type of ECG, you need not panic, and without predisposing background clinical history, diabetes or hypertension or strong family history, CAD, you need not diagnose coronary disease in young females, 30 premenopausal lady, 30, 40 years, then you find ST depression will be there, and usually within V2, up to V3 will be there, and there will be a asymmetry of ST. It is not a symmetrical T wave, asymmetrical ST depression and T inversion. This is called persistent juvenile pattern, and this is most of the time benign, nothing is happening. And ischemic T, I told you about, it can happen anywhere based on the ischemic zone. It corresponds to the area of ischemia, and usually there is a symmetrical T wave inversion. Whenever there is a pain, there is inversion, and it can revert. The dynamic T inversions are also very, very important in diagnosing the ischemia. That is the reason why we always ask for serial ECGs to assess the dynamicity of the STT changes. See here the myocardial ischemia and infarction. You always look into a T wave inversion is happening. It is symmetrical. Ascending and descending limbs are equal, symmetrical. So this is what you call it as ischemic T wave. See again, symmetrical T wave inversion. Time and again you will find symmetry, symmetry, symmetry. So you find almost symmetrical T wave inversion is always ischemic. Here the secondary STT changes. You find here the white QRS complex, opposite to that is the STT changes. White QRS positive, negative STT changes. This is secondary STT changes. See here, secondary STT changes. Whereas see here in this complex, it is a white QRS and you have same side STT changes. Same side STT. This is primary STT changes. See here, white QRS, you expect the STT to be on the positive side because it is predominantly negative. Now you find the same side of the QRS complex. This is primary STT changes. This is where you have to diagnose ischemia in a white QRS complex. So right bundle branch block, similarly you find opposite to the white QRS, opposite to the STT changes. This is a asymmetrical STT changes will be there. And this case, after the QRS complex widen, asymmetry, opposite to that is the T wave. You call it as secondary STT changes. There is nothing to worry. It is secondary to the bundle branch block. In left ventricular hypertrophy, where the left ventricle takes longer time to activate the repolarization, then the secondary to ST repolarization also will be on the opposite direction. That is the reason why you have in left ventricular hypertrophy, you have STT changes. You can add these two, S in V5 and S in V2 and R in V5, it will be more than 35. That means LVH is there, left atrial enlargement is there, and you have strain pattern in this ECG. You call it a secondary STT changes. So this is all normal secondary to the LVH, not with the ischemia. Here again, you find there is a asymmetrical T wave inversion. That means it is not likely to be ischemic. Most of the time, it is secondary STT changes due to hypertrophy. Similarly, in a right ventricular hypertrophy, where you find there is a STT depression which is happening, asymmetrical, secondary to the STT changes, you find this. In pulmonary embolism, where there is a strain pattern on the right ventricle strain, you find in anterior leads, you find the STT changes will be there, where you find ST depression in the anterior leads. Typical tachycardia, ST depression in the anterior leads, S1 Q3 T3. See here, S1 Q3 T3, typical of pulmonary embolism. This is how a simple ECG will give a clue of pulmonary embolism in an acute breathless patient. In hypertrophic cardiomyopathy, you will find slightly deeper T inversion. So usually less than 5 millimeters is ischemic. When it is more than 5 millimeter, that is here you are seeing 7-8 millimeter, then you start suspecting hypertrophic cardiomyopathy. So now you see this is not ischemic because it is much deeper. Ischemia is not this deep. Usually ischemic only, except for acute MI, most of the time the ischemic T wave will be less than 5 millimeter. When it is deeper without MI changes, see the tall R wave, deep in T waves, straight away you see hypertrophic cardiomyopathy. Raised intracranial pressure, you see that bizarre deepest T wave. Bizarre deepest T wave. If you happen to see this T wave, then you call it as raised intracranial pressure, where patient will have CVA, and this is not due to acute ischemia. That is due to the imbalance in the sympathetic and parasympathetic activity happening in the brain, which can cause myocardial necrosis, micronecrosis, which can cause this deep bizarre T wave inversion. Coming to the next way of analyzing the T wave, biphasic. So biphasic T wave, the first component in the T wave is positive, the next component in the T wave is negative. So I always told you the last component should be negative for ischemia. Whenever there is going to be the last component, first component is positive and last component negative means it is due to ischemia. Here, the first component is negative and the last component is positive. It is due to hypokalemia. A simple biphasic T, you are diagnosing two different diagnoses. One is an emergency. Second is also sort of emergency to prevent VT and VF, but correcting electrolyte abnormalities, it is correcting the revascularization. So how different? A small initial positivity and then terminal negativity of the T wave, we think it is ischemia. Initial negative and then final positivity, we think it is hypokalemia. Simple thing. So another way of diagnosing, last class also we saw about the Whelan syndrome. There is a way to diagnose Whelan syndrome. Usually happens in the anterior chest lead V2, V3, V4. See here, there is a symmetrical T wave inversion. With pain, it normalizes. Without pain, it will be like this. The other part of that T wave inversion will be, see here, there will be initial positivity, but always there will be a terminal negativity. Always terminal negativity. you think it is ischemia. The other type B, another way of Ehlers syndrome is deep T wave inversion. The anterior leads with pain, it will normalize. Without pain, it will have deep T inversion. You have proximal LAD 90-95% stenosis. It is almost equivalent to having an anterior MI. So this should be addressed very quickly. Otherwise, the patient will land in an acute MI. The next T wave will be, see here, there is a ST segment, QRS complex, ST segment, T wave. Another wave is there. And this is a P wave followed by a QRS complex, the prolonged PR interval. The P wave is happening very close to the T wave, giving a rise to a camel hump. See here, it is like a camel hump. See here, it is camel hump. Because it is a complete heart block, the P wave is marching across. It is falling on the T wave. You call it as a camel hump P wave. So T waves. So if it is happening, it means either the P wave is associated here with a prolonged PR into a first degree block, it is dissociated with a complete heart block. So if this camel hump, you always suspect complete heart block. You might find if there is bradycardia, most of the time it will be complete heart block. So this is how the camel hump will be there. Some other times the ischemia can present with a flattening of T wave with the brain and then normalizing. See here, some ECGs will have ischemia, then you will have a flattening. There is not the same T wave which is happening. T wave will be flattened, then it will be returning to normal over a period of time. So this dynamicity of flattened T waves will also suggest there is a possible ischemia. And you should also not miss, if there is going to be presence of UVA, you should not miss hypokalemia as well. Right? So today we saw about the ST segment and T wave. I'll summarize very quickly. ST segment, you should always look into the J point. If there is rapid J point depression, rapid upsloping ST depression, with reaching the normal baseline within 1 or 1.5 small squares, that is normal. Usually you see in a treadmill testing or in a tachycardia, we need not panic about it. When there is horizontal ST depression or downsloping ST depression with abrupt transition from ST to T wave, we call it as ischemia. That is going to the ST segment depression and there is a critical ischemia, subendocardial ischemia which is happening. So it has to be addressed very quickly. The T waves are very important in your cardiology practice. When in younger pediatric age group and young females, you can have persistent ST depression and T wave inversion. This is normal. These T waves and ST depression will be asymmetrical T wave and deep wave, and this small ST depression, T wave inversion will be there. Usually the ischemic T wave inversions are less than 5 millimeter. Most of the time it is symmetrical T wave. It means ascending and descending T are most equal. If there is going to be biphasic T wave, the initial positivity will be there. Ischemic T always will have negative T and negative final T wave. Whereas in hypokalemia, initially there will be negative, final there will be positive followed by a U wave. This is how you have to differentiate between ischemia and hypokalemia. Ischemic T waves are very, very important. The dynamicity is also very important. So that's the reason why you got to look into serial ECGs and see for the dynamic changes in the ECG. When there is dynamic changes in the ECG, you can think it is ischemia. Sometimes in Whelan sign, what I was telling about, you will have T wave normal during pain and deep T wave inversion in anti-leads during without pain. So that means that there's a critical ischemic changes and pseudo normalization of T wave happening during pain. So this patient also will have a LAD critical ischemia and requires emergency attention. Differentiate between the tall hyperacute T wave, wide based ST segment, the slight elevation, wide based T wave, the broad T wave, blunted apex, you call it as hyperacute T wave, and it requires emergency attention because it is evolving into a big MI, whereas a narrow base, tall tented T waves, you call it as hyperkalemia. Most of the time patient will have renal failure and hyperkalemia. So this is how you got to analyze the ST segment and T wave. With this, we finish the ST segment and T wave. If you have doubt, I'll just unmute and you can always ask your doubt. Everybody can unmute yourself and ask doubt if there is anything.